Okay, good morning, everyone. Thank you for joining. My name is Angela So, and just wanted to start off and just introduce our two speakers today, and then we'll jump right into it because we do have probably a full hour worth of content, but we would, ideally also like to have, be able to take and address any questions towards the end. So today's webinar represents a partnership between the Center for Clinical and Translational Science and the Department of Bioinformatics. And today we're just going to present an informational overview of various informatics systems for research, study, feasibility, and cohort discovery, including I2B2, the ACT network, and PCORnet. Today, our first presenter is Amanda Carroll. She's going to talk to you today about I2B2 and the ACT network. And Nina Thomas will also be joining us later to present an overview on PCORnet. And so with that, I'm going to go ahead, Amanda, and make you the host so you can share your screens.
Okay, great. Thank you. Oh. Can you all see the correct screen?
Yes.
Okay, great. All right, hi everyone. My name is Amanda Carroll, and I am the I2B2 and ACT data steward here at OSU. And today I'll kind of be giving a brief overview of what I2B2 and ACT are, some general information about them, and then hopefully a quick live training for you. So what is I2B2? I2B2 is Informatics for Integrating Biology at the Bedside, otherwise known at OSU as RDR, which is Research Data Repository. So it's funded by the NIH Roadmap, National Centers for Biomedical Computing. It's a database populated with coded limited data sets, which has been pulled from the IW. And then the big question is who can use it? So it's specifically designed for faculty and staff, no students, affiliated with OSU, Wexner Medical Center, and/or one of the 7 health science colleges. So it's a computational framework that enables biomedical researchers to use existing clinical data for discovery research. So it's IRB approved. It is IRB approved, interactive, and flexible framework that allows for self-service cohort discovery. So this can provide access to aggregate data counts. It supports research applications, minimize administrative burden in regards to those applications. It helps identify the number of existing patients who meet specified criteria, specifically at OSU, and it can help support a hypothesis for feasibility analysis. It can check for enrollment reports for the population, and then increase transparency regarding clinical data elements. So researchers can use I2B2 to help identify an aggregate number of available subjects matching their search criteria under the protocol, and this is not the actual subjects or their data. It's just an aggregate count. So then what is the ACT network? The ACT network helps clinical investigators explore and validate feasibility for clinical studies using electronic health records. So you might think, well, this sounds really familiar. You just said I2B2 does this. This is true, I2B2 does this. However, ACT does this on a larger scale. So with ACT, you can query 57 CTSA sites. It has over 130 million patients. And how it works is it's a local installation of software, ontology, and data connected to a large hub. As you can kind of see in this diagram, we would be, for example, site A. We talk to the hub, and we can pull information from all these other sites. So here's a brief overview of kind of who is involved with the ACT network, a list of all of the institutions involved. You can also see from this that there's about 5,000 end users, about 26 institutions. However, there's 57 CTSAs. So some sites of the 57 might not also query, they just provide data, which is why there's about 26 institutions that actually are polling using end users. There's about 440,000 queryable data elements and 130 million unique patients. So it's pretty vast and it's growing really quickly. You can see listed there's many universities that are staging for ACT, which means they're in the process of getting ACT at their institution to expand the network. So the ACT network, so it runs through the SHRINE, which is the Shared Health Record Information Network, which is a hub, and it's the user's gateway to an ACT network via real-time queries. So you can see where the dot over Columbus, where we would query to the SHRINE hub, which is in Boston at Harvard, and then it goes out to the individual site, pulls it back to the hub, and gives us the data. So this is kind of a quick overview of how that works. So you log in using the SHRINE authentication to the ITV2 PM cell, and then it goes through the query endpoint, which is kind of it's the endpoint that faces you so that you can query, and that goes, as you can see, to the hub. So then the hub goes out to the different adapters, which goes to the Hive, and that's kind of how you get all the information. Then it actually comes back through the same way, so back to the hub, back to the query entry point, and that's where you can see it on your interface. So what kind of does ACT do? So ACT can help you understand a cohort. So an investigator can have an option of queries and graphs based on a number of demographics, as you can see below. So this is based off of age and site. So it tells you how many people of different age groups at these different locations exist. So it kind of helps you understand your cohort better. It can also help identify study sites, so it can help researchers and investigators understand potential sites that they would want to collaborate with. So you can see an aggregate count of the number of patients from that site, and so you would see from this that the large purple one is probably someone you'd want to collab with, since they have a lot of patients with your criteria. So some strengths and weaknesses with ACT. So some strengths is that it's open access and available to research in the 7 health colleges. It's at no cost to users. It's an interactive desktop searches, or has interactive desktop searches, real-time query, demographic data enables study refinement, and it's the largest network in the world. So some weaknesses is that not all sites are up at a given time. Some sites go down for maintenance or just issues, and so you might not be able to access every single site at a given time. It's not as good as the clinical, so it is as good as the clinical coding data. So some sites code their data better than others. They have better electronic health records, and depending on how they code that into ITV2 and ACT, it's just as good as the data that you get. So the results are dependent on accurate query design. So it's up to you to design your query correctly to make sure that you get the most accurate design. And if you're not as familiar with that, or you're having some issues, then your results are only as good as that. So here's some available data elements for both ACT and ITV2. So there's patient demographics, such as vital signs, birth date, death date, age, so on and so forth. Encounter information, so encounter start date, end date, locations, and all that information. Then you have diagnosis, so there's both ICD-9 and 10 codes, and then there are some institution-specific codes within it as well. There are some lab results, so there's like start time, value, and units, and so on. There are procedures, so CPT and ICD-9 codes for billing, and then there's medication information, but this can be relatively limited. It depends on the institution. So here's some other extra information. OSU includes data from a 5-year rolling window in SHRINE. Other hospitals have different timeframes for the queryable data stored in SHRINE. I looked this up to see what the other institutions were, and for example, Harvard, I think, goes all the way back to the 40s, so a little different than OSU. If you run the same query multiple times, you may get a different number each time. The aggregate count is an estimate, and so, and then also on that, the system is designed to lock you out if you run it multiple times, because it thinks that you're looking for an exact number, because you can just average them together. And so it'll actually lock you out to protect patient safety. So ITV2 and ACT data oncology refresh and scope. So the ontology has demographics, provider, encounter, so on and so forth. Data refresh, OSU ITV2 data is refreshed every week on Saturday. And the data scope, it includes data within a 5-year rolling window, as I said before. OSU ITV2 includes data on OSUMC patients only, not children's or anything like that as well. Data associated with prisoners are not included. Data associated with Madison County patients are not included, and over 89 will always say just greater than 90. So what is ITV2 and ACT not used for? The IRB protocol specifies that ITV2 and ACT cannot be used for the following. So it cannot be used to deliberately identify a patient from the aggregate data. It cannot be used for data rendered by the ITV2 ACT interface to be used directly for research or statistical inference, and it's not used to support any aspect of patient care. So the IRB states that investigators must agree that they will inadvertently recognize the identity of a patient. They will seek immediate IRB approval to continue working. So query analysis and output options. So the following output options are available. So you can get patient set, an encounter set, the number of patients, the gender patient breakdown, vital status patient breakdown, race patient breakdown, age, and then timeline. And so you can use all of these things to gather up your information and see your different breakdowns so you can better understand the data. And then we're going to do a quick ITV2 demo. So this is the ITV2 client. So I went ahead and logged in with my username, or can you all see this? Angela, can you see the ITV2 login?
Yes, I can see it, Amanda.
Okay, thanks, Greg. Okay, so once you log in to ITV2, you'll be asked to select a project. So you'll go ahead and select RDR ITV2 prod. And this website, this website is itv2.osumc.edu. So once you get into ITV2, this is what it looks like. You can see up here all of your terms that you can open and see all of the different, your different terms to be able to query with. And then these can go on for a while. You can keep opening folders, or you can just search as well to drag over terms. Then there is a shared folder where you can store old queries or old queries or saved queries. And then you can also see your previous queries down here that you're welcome to drag over if you want to, check on a specific query throughout a year to see if the numbers are changing or if you're getting more patients in that area. You can always just drag over an old query and it will run it again for you. So the way that this interface works is that you drop a term in the first column, and then it reads across as this or this or this, and then down the column it reads this and this and this. So you'll say, oh, sorry, that is the opposite. It's down as or and then across as and. So you'll want them to be 50 to 59 years old, or 60 to 69, or 70 to 79, and you want them to be not Hispanic or Latino. And then you want, we can find a basic procedure, so just a basic radiology procedure. So this reads any one of these and this, and then you would hit run query. You want a number of patients, which is just your aggregate count, and then you'll hit OK. And it will say down here that it is running the query, and it will give you how long it's been running for. And so we get our query came back. We have 14 patients. Again, this is just an estimate. There might be a few greater or less than 14 patients. And then you can see a report here if you want to be able to, for example, like print this out and provide it. It gives you all of your information, and then you can print it here at the bottom. So this is just an overview of how ITV2 works. You can, of course, play around with it and see what you can get. Some queries, if you make them in like super specific, they can run for a pretty long time. So we recommend maybe going broader at first and then narrowing your search if you're getting too many patients. So then on to ACT. So next steps. So to gain ITV2 and ACT access, all users must have a MedCenter account information. It's only available on the MedCenter network or VPN. Accounts created and never logged in will lose access after 90 days. And then if it's unused, it will lose access for 365 days. So for ITV2, you'll just need to complete the data use agreement tracking. And then for ACT, you need to complete the ACT terms of use form. And then so a quick ACT demo. So this website is, let's just log in. It is shrine.osumc.edu. You'll log in with your MedCenter username and password and make sure your Shrine host says Shrine here, and you'll log in. Then from Choose a Project, you'll have to click on Shrine and then hit Go. Once you log in, you'll need to request a topic, which is right here. So you'll hit Request New Topic. You'll log in again with your information. You'll hit New, and then we'll say New Test for Demo, and you'll hit Submit. Then close out of this, and then log out of ITV or log out of Shrine. This is important. Remember to log back out, or your query topic will not show up. So log back in again, choose Shrine again, and then your topic should be here. So I chose New Test. So you choose your topic, and then again, you bring out your information. So we want it by this, and you'll notice some of the brackets are different. They vary between ITV2 and ACT in some ways. For example, age. You saw that ITV2 went in like groups of 10, whereas Shrine is a little different. So you just have to be careful about these things and make sure that you're querying what exactly you need. So we'll do the same information. And then again, you hit Run Query. And then you can choose which breakdowns you want. So I want it broken down by age and gender. So then it will say down here that it has been submitted. And then it will say, kind of give you an update of what's happening. So it'll tell you when it was last updated on, it will tell you that it's still in progress, and then it will say that what's happening at each institution. So you can see here that it's been sent to the sites, and we're just waiting for information back. So this has been processing. Sometimes you'll get a site error, and it will allow you to click to see what that means. And depending on what this says, it might mean that their node is down, and that they are just not accepting queries right now, or different things like that. So then you can see we got our first couple of responses. Ohio State is 25 plus or minus 10 patients, which kind of makes sense when we got 14 the first time. So it's around somewhere between 14 and 25. So Penn State has a lot more patients, Stanford as well. So you can see some of these are delayed, and we could look into what's happening with those. It might be an issue with the server or things like that, but you are getting some patients back, which means that your query did go through. So this is just kind of a brief overview. Obviously, it kind of went really fast, and there's a lot more information to it, but does anybody have any questions at this time? Feel free to unmute and go ahead and ask any questions. All right, well, if there's no questions, then I'm going to pass it all over to Nina, and she can go ahead and start talking about PCoreNet.
Hi, can you hear me?
We can hear you.
All right. Thank you, Amanda. Do you see the correct screen? Do you see my screen?
No, I don't see it, Nina.
Okay. Give me just a second. How about now?
Yes, see that now, PCoreNet.
Okay. All right. Thank you. All right. Good morning, everyone. My name is Nina Thomas. I'm a BMI consultant in the Department of Biomedical Informatics. I'm also the project manager for the PCoreNet Consortium at Ohio State. Today, I'm going to give you a brief overview of the National Healthcare Database called PCoreNet. So let's start with the network and see how it is structured. Give me just a second. For some reason, my slides are not moving. Give me just a second. Okay, how about this screen? Can you see my screen slide moving?
Yeah, we can see your slides move.
Are you able to see the second slide?
Yes, the network.
Okay, all right, great. Sorry everyone about that. Okay, so let's start with the network and see how it is structured. To understand the network, the PCoreNet network better, I will start with PCORE. Some of you might be familiar with PCORE or might have heard about PCORE or might have heard about PCORE funded studies or research. For those of you who have not, what is PCORE? PCORE is the Patient-Centered Outcomes Research Institute. It was established by Congress to fund research that can help or improve quality and relevance of evidence available to help patients, caregivers, insurers, policymakers to make better informed decisions about healthcare choices they face. PCORE or Patient-Centered Outcomes Research, it's a type of comparative clinical effectiveness research or CER, which means it's a research that identifies what clinical and public health interventions work best for improving health. And this was authorized by Congress in 2010. In order to answer these questions, what PCORE did was they funded a distributed research network called PCoreNet or Patient-Centered Outcomes Research Network in 2013. So think of PCoreNet as a network of networks. It is basically a collaboration of several networks that support research using health data collected in the course of care through electronic health records. There are also some claims data and some data which is directly collected from patients. And there are more than 100 health institutions across US that are part of the PCORnet. So PCORnet is able to harness this large amounts of health data and patient partnerships. And what the distributed research network, what it means that each of the organization's data stays within that organization. So when we get a question from PCORnet, each of the institution, they basically run the question at their own site and they respond back with only the answer. So this is what makes PCORnet faster and cheaper. And I'll go into more detail about how this is achieved when we talk about PCORnet data. So we said that PCORnet is a network of networks. It's a tightly integrated partnership of two different kinds of network. There is the clinical research network. There are 9 clinical research networks and 2 health plan research networks. And there is one coordinating center that support the infrastructure and research of PCORnet. So a clinical research network, what it is a group of 5 or 6 or 7 healthcare institutions or academic medical institutions, similar in size to Ohio State. They come together based on their geographic location or based on the research that they are interested in, and they form one clinical research network. So similarly, there are 9 clinical research networks in PCORnet. Ohio State is part of the clinical research network known as PATH. So all the other partner sites in PATH are lies in the same geographic location as Ohio State. But there are some other CRNs like PedsNet. PedsNet, they are the pediatric research network. So Nationwide Children's, Boston Children, Cincinnati Children, they are all part of the Peds network. And then Health Plan Research Network, what it is through CRN, PCORnet have access to vast amounts of electronic health record. But sometimes there are gaps in this data with claims data. So in order to bridge this gap, what PCORnet did was they funded 2 major US health plans. One is HealthCore, which represents the Anthem Research Network. And the second health plan network is PracNet, which is a partnership between Humana and Medical Outcomes Management. The coordinating center, which supports the infrastructure of the PCORnet, and which acts as a central hub of the network, they are a collaboration between Duke Clinical Research Institute and Harvard Pilgrim. So this image shows how we are part of the PCORI consortium. So we are part of the PATH, which is a clinical research network of PCORnet, which is the distributed research network of PCORI. Now let's look at the PATH network. So there are 7 member sites in PATH. Pittsburgh is the lead site. The other member sites are Johns Hopkins, Temple, Penn State, University of Michigan, Geisinger, and Ohio State. At Ohio State, our site PI is Dr. Soledad Fernandez, who is the Vice Chair of the Department of Biomedical Informatics, and she's also the Director of the Center for Biostatistics. So now that we have talked about the network, let us see how the data is, what the data is, and how the data is structured. And let's see what makes PCORnet faster, cheaper, easier. So how this is achieved is, PCORnet developed what is called the common data model. So the common data model, what the common data model, can you see the animations or is the slide stuck?
It's a little stuck.
Okay, all right, so sorry about that. So, but can you see the common data model? All right, let me talk about it. And maybe once I share the slides, it will work better. I'm sorry, I don't know why it is stuck. So the PCORnet common data model, what it does is it organizes data into a standard structure. Each of the member site in each of the network, they map their local data into the same consistent format. And this platform enables rapid responses to research related questions. For example, as you might be aware, at Ohio State, our EHR is EPIC. So there is a way in which that our data is structured into our Epic EHR. Maybe one of the other partners side there, EHR might not be Epic, it might be Cerner. So their data is structured different in their EHR. So when someone asks the same question to each of these sites, they will have to word the question in different way at each of the sites so as to obtain the same answer. So what PCORnet does is they're telling each of the institutions, hey, pull your data into this same structure and keep it in that way so that we can send the same question to each of you guys and you can run the same question at each of your site and get the answer back. So this means that each of the member site only have to run the question. They do not have to structure the question. So this is what makes this rapid response to research related query. And the quality is ensured through a process called data curation. So basically the CDM has a subject table called demographic. I don't know if you're able to see the subject table. So the demographic table has all the demographic information about a patient, like patient ID, birth date, then gender, race, ethnicity. PCORnet is a coded limited or a de-identified or a coded limited data set. What it means is that all the data is de-identified, but we have actual exact dates, service dates, associated dates, and exact zip codes of patients available in our database. Then the other data available on patients are, there are encounter details, medication details, vitals, labs, diagnosis, conditions, all of these details are present. So like I mentioned, we do data curation to ensure the quality of the data. The data curation is done once every 3 or 4 months. So our last data curation was approved on April 13th. And on April 13th, we had a population of around 1.25 million patients in our demographic table. So if you're requesting data from the OSU local data, this is what you are getting. Then if you want to take it one step further, you can request data from the PATH network level data. So PATH has all these 7 member sites. So that means this data is from late last year. So if you look at it, you can request data on patients of around 14 million if you're requesting data from PATH. And you might get a better distribution of data from each of the different sites. And if you're looking at PCORnet national level, you have access to close to 100 million patients. The current data that I'm showing, it's from last year. So currently they have more than data on more than 100 million patients. So you have all this wonderful data. How do you request the data? Data can be, the aggregate data can be requested at the national level from PCORnet or network level from PATH or local level at OSU data, from the OSU data set. In the national and network level, if you are requesting de-identified data set, you can request it with a signed data sharing or data use agreement. At Ohio State, if you are a researcher within the OSU Wexner Medical Center, you can have access to the coded limited data set based on your research request. So it will be a one-time data pull based on your research request that we can provide you the data. So are there any fees associated with pulling the data? There are fees associated with it. At the national and network level, when you submit a request, the respective teams will work with you to work on the budget, and they'll provide you a cost estimate of how much it will cost. At Ohio State, we charge based on the hours it will take to create a query. So it is charged per hour. The process by which you can put in the request. For the national level PCORnet data, you can go to the PCORnet website and there is the contact us page. It is called the front door. So you basically enter your request there. Then the PCORnet, the coordinating center, they will take a look at your request and they will let you know if it is approved or not. Similarly, at the path level, you can go to the path network website, and there is a link where you can put in a request, and you can request data of the 7 member sites. For getting access to the local OSU data, the data request form is available on the BMI website. It is called the PCORI data request form. So we also have a u.osu.edu page for PCORI. I will link that page in the last slide. And all of these details are present there. So it would be good to keep the u.osu.edu page on hand if you're interested in requesting data. Now, this image, it shows the process by which data is requested through PCORnet. So once a requester puts in a request through front door, the coordinating center takes a look at your request, and once they accept the request or approve the request, a query is created and it is pushed to each of the member sites. And each member site has they can say no to responding to a query, but if they want to respond, they send back the response to the coordinating center and it gets back to the researcher. So usually the turnaround time is about 2 weeks, but there have been certain rapid response queries which they request answers in as less as 3 or 4 days. So what is the scope of PCORnet? What are some of the things that you can do with PCORnet? So it can be leveraged for a wide variety of studies like feasibility studies, phenotype validation studies, clinical trials, registry linkage studies. Let's take a look at a few of the examples that we have taken part as member of PCORnet. So the first kind of study is feasibility studies. Feasibility studies, as you know, it's to find the aggregate count of patients to verify feasibility for conducting a study or site selection. So for example, someone wants to find out the feasibility of conducting a study for acute kidney disease. This is like a very, very simple, request. So you can construct the query. Once you put in the request through PCORnet, the PCORnet front door team can work with you and they can construct the query based on ICD codes, diagnosis. And if the member sites decides to respond back with the answers, the counts that you could get might look like this. So this is not actual data. This is just a depiction of what the counts could look like. So you will get this data from each of the member site and you can decide the feasibility of the study based on the member site or the network. The second kind of study that we have done as part of PCORnet are validation studies. So basically a computational phenotype, it's a method for identifying patients with special characteristics based on the structured data like diagnosis, medications, demographics, etc. So PCORnet provides a great background for checking these validity of these models. So one of the studies that we took part in was a nephrotic syndrome CP validation. What we did was we received the computable phenotype from PCORnet. So we ran the computable phenotype against the PCORnet CDM, and we received a certain count of patients. At that time, in order to validate the computable phenotype, we applied for an IRB. Once IRB was approved, we identified the patients that we found from PCORnet, and we selected 50 patients who had the case and 50 non-cases. And then we did a manual chart review of these 100 people in order to see if what was pulled out of the validation model was accurate. Another kind of study that we have done as part of PCORnet is linking patient-reported outcome or adding survey data to the existing data in the CDM. So we did 3 or 4 cohort studies based on this model. One of the studies was a heart failure cohort study to identify if certain factors like patient-centric factors like family support, community support, your care team support, does it lead to better improved outcomes for heart failure patients? So they wanted to validate a model known as the chronic care model. And the hypothesis was that better self-management, family support, and better care team, it leads to improved outcome. So what we did was, we identified a cohort of heart failure patients from the PCORNet CDM using an HF phenotype. Once we got this cohort of patients, we submitted an IRB and we identified the patients from our electronic health records. And then we contacted the patients to see if they were interested in responding to a survey. We contacted around 2,500 patients, and of that, some of them said, yes, we are interested. So to those patients, we sent a survey questionnaire, and we got back results from around 400 of these surveys. So we de-identified the results that were collected, and now we are in the process of linking this survey results to these patients in the CDM. When we're talking about linkage, we also tried another kind of study where we linked registry data to the existing CDM data. So registry data, they often have data about people with a specific health problem, but it is usually data associated with the problem that they had on hand. It might not contain data 5 years prior to the event that occurred, or maybe 10 years down the line if you want to follow a patient who was in a registry. That data is not present in registry. So PCORNet thought it might be a good idea to try to link an existing registry data to the CDM data that is available at the sites. So the registry they chose was a TVTR, or transcatheter valve therapy registry. So any patient in the US who get a heart valve replacement surgery, they are part of the TVTR. And TVTR contains their basic patient data, date of birth, their surgery details. But after the procedure is done and after the follow-up visits stop, there are no other longitudinal data available, and there are not much historical data available for these patients. So what we did was, we identified patients who underwent heart valve replacement surgery at Ohio State based on the CPT codes. And for those patients, we looked up the data in the TVTR registry, and we linked that data, and we were successful in linking about 96% of these patients. And one of the other criteria for this project was that research team thought that it would be good if we have an extra set of data called echo data. Echo data is not present in our CDM, and it is not present in the TVTR registry as well. So we created a separate supplemental table for echo data for these patients, and we linked that data to the existing CDM as well. Then the next kind of study that we have done is clinical trials. So clinical trials, it is really easy. Clinical trials are very hard to set up. But when you make use of the existing infrastructure of PCORNet and its patient partnerships, it makes it easier to get the ball rolling on a clinical trial. One of the clinical trials that we are part of is called Adaptable. Adaptable is a large national pragmatic study to determine whether 325 mg or 81 mg of aspirin is more effective for patients with heart disease. So the method here again is similar to other studies that have followed a PCORNet protocol. So we basically identify patients, initially identify the patients from the PCORNet CDM based on the phenotype. Then once we get the count of patients, we submit an IRB to identify these patients. And then we follow all protocols, recruitment protocols within each of the individual sites. Then we contact patients for recruitment. And once they are enrolled, the patients are provided a unique ID, a unique trial ID. And this unique trial ID is entered. There is a table in PCORNet CDM called PCORNet trial. So that ID is entered there. So we can follow these patients based on the trial ID. and see how they are doing longitudinally. So the PI for this study at Ohio State is Dr. Brent Lampert. Our enrollment for this study is complete, but the study is ongoing. So this was how the study design looked like. And there are still a few more months before this study completes. So these are some of the studies that, some of the types of studies that we have done as part of PCORNet. The next thing I want to mention before I conclude my presentation is the current situation that is going on. So, I mean, this situation, the COVID-19 situation, it has changed this unprecedented situation has changed our life completely. And at this time, the need for patient-centered insights and answers have become more pronounced. So what PCORNet did to respond to this current crisis, one of the things that they did, or they are in the process of doing, is creating a PCORNet COVID-19 data model. So PCORNet already has this simple structure of data, de-identified data that is present at each of the institutions. So they thought that they can get a quick snapshot, basic snapshot of infected patients if they send queries every week and we query them against the CDM. So I had told you earlier that we do the data curation process every 3 or 4 months. But once the COVID-19 situation has come up, what we are doing to respond to this is we are refreshing a copy of our CDM weekly. This is a very intensive process, but we have been doing it. And we have been responding to COVID-19 queries based on that refreshed CDM to provide a national snapshot of infected patients. In the future, we are hoping that this will allow researchers to gather information of patients who have been infected and what the effects of the virus is on them going forward. Another response that PCORNet has had for the current situation is they launched what is called the HERO Registry in mid-April. So HERO, it stands for Healthcare Worker Exposure Response and Outcomes. It is a research program. What it tries to do is tries to unite healthcare workers across US and try to address the problem the healthcare workers face in real time. So the healthcare workers, it includes nurses, physicians, emergency responders, therapists, food service workers, any service workers that work in the healthcare setting, interpreters. So all of these people who work in a healthcare setting, they are defined as a healthcare worker, and that any healthcare worker can go to the HERO Registry website and they can provide as much details or as little details as they want. And based on the data that they provide there, these workers, these participants, they will receive certain surveys and they could also be selected to participate in clinical trials. So the registry follows a protocol developed by Duke Clinical Research Institute and there are data guidelines to keep all the information secure. So the study design consists of 2 parts. There is the clinical registry which has been launched, and there is also a clinical trial associated with it. I'm not going into detail about the clinical trial that's happening, but what PCORNet is hoping is in the future, this HERO registry will help speed additional clinical studies that address other unmet needs of healthcare workers. So these are some of the things that we have been doing. Any questions that anyone has at this time? And this is the u.osu.edu link. You can go there and you can get a lot of details about PCORNet, how it is structured at OSU in this page. And if you have any questions, you can also contact us at pcori@osumc.edu. Does anyone have any questions? All right, I will stop sharing and give it back to Angela.
Thank you everyone for joining. I think we can go ahead and conclude and yield back, 11 minutes to everyone's day. As both Nina and Amanda both mentioned, feel free to reach out with any questions. We do appreciate you joining us today. Take care.